Hi everyone, my name is Tom Fadile. I'm an assistant professor in the Department of Emergency Medicine at McGovern Medical School, and today I'm really excited to talk to you about metacognition. First, I have no financial disclosures for this talk. Our objectives today are to start with a definition of what metacognition is, but then we'll talk a little bit about the importance of metacognition as it relates to decision-making errors. I'll then spend some time talking about theorized processing models for how we think, as well as some specific emergency medicine related processing models. And then we'll spend some time talking about how we can get better. I first started learning about metacognition when I was an undergrad. I started off as a philosophy major and specifically studied philosophy of mind. Within a few years, it became clear that career options for philosophers out there is pretty limited, and so I eventually went to medical school and I'm now doing emergency medicine. And I brought those concepts with me. My first experience with metacognition as a clinician started in medical school. I had an amazing preceptor who worked in the emergency department and would set me off to see patients. I would spend 30 minutes or longer in the room gathering all of the necessary and unnecessary history, performing physical examination maneuvers, often incorrectly, and returning to my preceptor with a differential diagnosis that probably rarely was even in the right organ system. My preceptor would graciously come see the patient with me, and I could immediately detect a very big difference in how our encounters went. Whereas mine was lengthy, where I fumbled through irrelevant portions of their evaluation and came up with the wrong diagnosis, he went in there asking very specific questions, performing specific physical examination maneuvers, and left within minutes having arrived at the correct diagnosis. And when I asked to get a little bit of information about why our experiences were so different, the answer was unsatisfying. It was that this notion that I would just have to see more patients, and with time, I would have a chance of working like that. And this was very unsatisfying because it doesn't give you any power as a learner. If your recommendation is to just wait it out, it's hard to motivate yourself to learn. And so I started spending some time thinking about how my encounter went and how his encounter went, and this was metacognition. I was trying to analyze what my thought processes were that resulted in this incorrect answer versus his. Trying to understand the difference in processing between a medical student and experienced attending is a bit too big of a problem to tackle. What we'll start with is understanding how our thought processes might affect at least decision-making errors. So medical errors are a broad range. There are things like operative errors, like a wound infection or a technical complication. There are non-operative errors, things like incorrect medications or a fall while in the hospital. And then there are these categories of diagnostic mishaps or medical decision-making errors. And these account for a pretty significant portion of overall medical errors, something like 10%. But more importantly, decision-making errors or diagnostic mishaps seem to have more profound downstream effects. So it kind of makes sense if you arrived at the wrong diagnosis early on, that's going to lead to certainly delays in arriving at the ultimate diagnosis, but potentially lots of risk associated with incorrect therapies and unnecessary testing. What this means is that our diagnostic mishaps not only have more profound downstream effects, but within emergency medicine in particular, because our patients are so undifferentiated, we're still more prone to having these errors occur. If you compare emergency medicine related diagnostic mishaps versus other specialties, including visual specialties like pathology, radiology, or dermatology, our rates of errors are much higher, and it ends up causing highly preventable complications. We're going to talk about a few examples for some of these types of errors, just so we can get an understanding of how we might avoid them. So an availability bias or error occurs when we change our practice based on our prior experiences instead of maybe what is truly necessary. So say you had a patient who came in with leg pain, you do your normal and appropriate evaluation and discharge the patient home. And then you get that dreaded talk a few days later where someone says, "Oh, do you remember that guy?" And you're like, "Oh dear God." And it turns out that in a very uncommon way, this patient ended up having a myosarcoma, and that was their ultimate diagnosis. The way to debias from this availability error would be to specifically go through, review the prevalence of that disease, and recognize that it's probably normal for that disease process to require multiple presentations before arriving at the correct diagnosis. And perhaps instead of changing your practice and either exposing patients to unnecessary tests or other risks, you might recognize that, hey, this could happen. An anchoring error occurs when we just fixate on that first impression or that first diagnosis. So in this example, there's an elderly patient who sustains a fall. They're found to have a vertebral compression fracture, and that's what's targeted. And we end up not reviewing additional data that arrives. So things like an abnormality on their differential, which suggests that this might have actually been a pathologic fracture. Premature closure is a variety of error that I think we're actually very good at avoiding in emergency medicine because we're so finely tuned to not missing critical diagnoses. But in this example, there's a patient with a supposed diagnosis of diabetic gastroparesis coming in with what sound like recurrent symptoms. And because of a failure to consider all of the alternative causes, the true etiology of the recurrent vomiting, which was intracranial hypertension, is missed. Again, I think in emergency medicine, we're really good at avoiding this because we are so focused on not misdiagnosis. The point of discussing these medical errors is to understand, one, that we have a significant role as emergency physicians in recognizing that errors will happen. They're unavoidable, and we need to at least recognize the things that lend to their development. And without understanding or appreciating that we are going to all succumb to these biases, it's really difficult to work on getting better. I really enjoy this statistic that 94% of physicians consider themselves to be in the top one half of their specialty, and that's clearly impossible. And it's not a negative perception to have. We should all feel like we are doing the best possible job we can, and that we are in the top portion of our specialty. But that must come with some recognition that we are going to cause errors and that we need to introspect and learn about why they're happening in order to get better. So let's talk a little bit about how we think. There are two theorized processing models for how we arrive at diagnoses in clinical medicine. So system one is also described as intuitive. This system operates based on pattern recognition, and the quality is dependent on the practitioner's experience. This paragraph below is showing that you're actually able to read this sentence with almost no additional effort, because it turns out that all you really need is that the first and last letter be correct, and the middle ones can just be a bit jumbled as long as they're the right length, and you can still interpret the content with very few errors or difficulties. System two is also described as analytical, and this process is much more algorithm based. It's effectively what you're trying to do is use all the available data, process it, and calculate a specific percentage of the likelihood of a disease causing the patient's symptoms. I mean, obviously, it doesn't entirely work that way, but in its purest form, that's what analytical processing is trying to do. And there are pros and cons to the application of each system. So for system one, or intuitive processing, the capacity is high and the effort is really low. So if you think back about that paragraph that you read, you were able to do that with almost no extra effort, and you read the sentence at almost normal speed. If you compare that with the analytical system, if you're trying to put all of the available data into some sort of calculator and arrive at a specific percentage of disease likelihood, that's going to take a long time and it's going to take a lot of effort. For system one, some of the cons are that you might be more prone to error, and that's directly related to a relative lack of cognitive control. You may not have even known that you could read a sentence in that way, but you still did, and it might be that the lack of transparency on how that process worked could result in errors. If you don't know what you're doing or how you're doing it, you don't know if you're also doing it erroneously. Contrast that with the System 2 analytical processing, much lower risk of error, and that's because we have explicit cognitive control over our processing. Since we're using a clearly defined algorithm, as long as there's no errors in this algorithm, then the rates will be absent, and your ability to detect that is based on the fact that you can audit an explicit algorithm. And this has some other implications too with respect to avoiding unconscious biases. So if, for example, your intuitive system has incorporated biases that you're not even aware of, you can't audit that portion. You can't know where those biases are being integrated. But if you have an explicitly defined algorithm, it could still be prone to biases, but at least it's externally auditable. It turns out that it's not quite so simple. We most likely are using both of these systems in different times and depending on our experiences. And this is the dual process theory. So to go through an example, if we see a patient where we recognize the pattern, we will use our system one processing, maybe further calibrated based on some details of that patient encounter, and quickly and with little effort arrive at the diagnosis. If the pattern is not recognized, then we'll use our analytical system, try to devise an algorithm for determining the likelihood of them having a certain disease. That can further calibrate both the algorithm and eventually the pattern recognition process before we arrive at a diagnosis. And there are unfortunately other things that occur outside of the patient encounter that can contribute to whether or not we're using system one or system two. So for example, if a patient's presentation does not specifically match a pattern that we've identified before, but we are faced with lots of other difficulties during that time. So for example, whether we are personally sleep deprived or fatigued, or whether there are other conditions around our emergency department that are causing us to have not enough time or attention, we might try to fit a pattern into our intuitive system when that's not necessarily the safest thing to do. In emergency medicine, the system one and system two processing is even more complicated. We might use system one and system two for the same patient. We might use it for specific components of a patient's evaluation. So for example, an ECG, that's just one piece of the patient's evaluation, but we interpret it potentially using all of these systems. First, system one is just recognize whether or not they have a STEMI, and then system two might take a little bit more analytical approach depending on additional information that we have about the patient, where we might spend a little bit more time looking for precipitants for dysrhythmia if our illness presentation was one of syncope. Further, the evaluation of a critically ill patient actually conducts these processes in series and parallel. So say a patient arrives with respiratory distress. We must immediately use our intuitive process to recognize respiratory failure, and that term will serve as our working diagnosis while we proceed towards stabilization. If someone is having difficulty breathing, they cannot provide any history. Their examination would only delay supportive care measures, and so we have to use a quick, intuitive model to arrive at this working diagnosis. And so we immediately begin interventions. For example, in this case, we're going to apply non-invasive positive pressure and then maybe conduct a more detailed assessment to add to our working diagnosis. And in this case, let's say we did an ultrasound and we saw signs of volume overload, and maybe a quick review of the patient's history identifies some diagnoses of congestive heart failure. Now we are going to augment our management with the additional information, for example, by starting a nitroglycerin infusion. Not only that, our patients, we know, often decompensate. And so if a patient's clinical condition deteriorates or changes for some reason, we will actually conduct this entire process again, resuming at the intuitive level to start stabilization measures, and then conducting a more detailed assessment when that happens. So now we know a little bit more about how we think. We know what specific challenges we face in the emergency department, and we want to learn a bit about how we can get better. And to do that, we actually have to get a little bit of neuroanatomy. So there's this really interesting portion of your brain called the fusiform face area. And this area was first identified using functional MRIs of individuals with prosopagnosia, or a condition where they are unable to identify faces. The functional MRIs of these individuals showed that they did not have any activation in this area of their brain when they were shown a face compared to normal controls. And so the initial impression was that this area of the brain is solely devoted to identifying faces. But it turns out that it probably does a little bit more than that. They, again, used functional MRIs to evaluate experts in a visual domain and found that the fusiform face area could translate to identifying and improving processing of visual elements. So, for example, they did these fMRIs on bird experts and car experts. And so they would take a bird expert and show them a bird and a car. And there would be heavy FFA activation when the expert was shown an image in their clinical domain of expertise. And nothing would seem to happen when they were shown an image that was outside of that. And they contrasted that with the car expert. Same thing happens. When they saw a car, huge FFA activation. When they were shown a bird, nothing special. And so now we've extended this fusiform face area to serve not only face identification, but now maybe even a role in interpretation of visual stimuli in an area of expertise. And so this was extended a tiny bit further. They started studying chess experts and whether or not the fusiform face area was active when they were processing chessboards. And they did this in a very interesting way. So they would show the chess expert a chessboard that was naturalistic. And what that meant is that the arrangement of pieces could have reasonably occurred if they were playing a game of chess using normal rules. When the chess expert saw a naturalistic chessboard, they had heavy FFA activation. And when they were shown a non-naturalistic chessboard, there was none. The non-naturalistic chessboard in this case was a chessboard with an arrangement of pieces that would never have occurred if someone was playing chess using normal rules. And so now we've gone one step further. we know that the fusiform face area can do more than faces. It can do more than just visual stimuli, and it seems like it can process data that would be represented algorithmically. And so now what we would like to know is this something that can be trained quickly? Or are we again talking about, in the case of, chess players, the 10,000 hours, or in the case of my preceptor, decades of training to achieve FFA augmentation of this processing? And it turns out that no, this can happen quickly, even on the order of minutes to hours. So there was this really interesting study, again using functional MRI, evaluating the fusiform face area, where they got these test subjects and asked them to learn how to interpret a generated 3D model. And so the researchers created these realistic 3D models and asked the subjects to identify whether they belong to a particular family or gender. And you can see they have these sort of bizarre names. The class of these 3D objects were termed greebles, and they're divided into families and genders to just describe what they were trying to teach the subjects. You can see that the glip gender has sort of upward pointed ear things, versus the plock gender had these sort of downward shaped ear things. The families seem to be more divided by the shape of the body. You can see that some of them have kind of wider, more rounded structures, where other have sort of more columnar or kind of narrow waisted structures. Anyway, what they showed is that the test subjects not only were able to learn how to categorize the greebles when they were presented, but that they did this using their fusiform face area. They showed that over the course of the study that the test subjects had heightened fusiform face area activation as they learned how to categorize greebles. And then if, for example, they either showed a new 3D model or they would invert the 3D model, there was no fusiform face area activation. So now we know a few things. It's not just for faces, it's not just for pictures, it could be used for algorithmic processing, and you can quickly learn how to do this and potentially augment your performance. It's very likely that clinicians utilize their fusiform face area when interpreting patients in this sort of intuitive way. The classic notion of detecting whether or not a patient is sick is probably heavily involves this area. There's unfortunately no specific research that's been done to evaluate this topic specifically, but hopefully we can extend to that based on some of the information about FFA studies that I just described. So when clinicians were shown pictures of individuals with critical illnesses versus those without, um, the clinicians were able to determine the acuity of the patient's presentation with a range of sensitivity ranging from 66 to 72%, which is not great, but clearly we are able to get some information from just that immediate impression of a patient. Our ability, unfortunately, to detect things more specifically, like the rates of ICU admission, were a bit worse, something like 34%. And so what I'm hoping to describe with all of this is that as clinicians, we probably use the fusiform face area to identify whether a patient is sick or not sick, and potentially other critical aspects of their evaluation. And I hope that we can agree that it's likely that we can train our fusiform face area and do so more quickly than what my preceptor suggested. That perhaps if we can prime our System 1 intuitive processing with a viable, auditable System 2 analytical algorithm, that we may be able to reach that level of expertise sooner. Because from what I've described about how medical decision making, processing, and the specific constraints in the emergency department, it's clear that System 1 processing is a prized value for a clinician. To be able to quickly identify whether a patient is sick and in what way, or at least using that information to arrive at a working diagnosis, that is a key function of an emergency physician. In order to prime System 1 with System 2, we have to create algorithms. And that's what I've spent the last few years trying to work on. I created something called Differential Diagnosis of, or DDX of, which is a library of clinical decision support, diagnostic, and management algorithms for emergency medicine. And the topics range from things like chest pain to severe burns. And the objective is to create a public, auditable System 2 algorithm to prime our System 1 processing. And just to show a few examples, the range of complexity is dependent on the complaint and the audience. In this example, the topic is chest pain, and our audience was medical students. And so I created this algorithm that uses the underlying knowledge that they have to try to generate a analytical process that they can use and potentially expedite their transition into intuitive expert clinicians. You can see here that it shows things like using a chest x-ray to interpret the possible causes. As our trainees become more experienced, we start to fracture the algorithm on more complex features. In this algorithm for dysphagia, we divide the possible causes based on some features characterized by the patient, as well as specific functional processes that result in that symptom, things like luminal obstruction, motility problems, and so on. An algorithm for severe burns takes into account how we function in the evaluation of trauma patients. So instead of trying to create a pathophysiologic division for the evaluation of patients with burns, we follow what we know, which is the trauma survey. And then I'm just terrible at remembering all the things for Kawasaki disease, so I just have to have one of those. The content for DDX of is available online for free. I think we're up to well over 100 algorithms at this point. And I'm also happy to say that there is a free mobile application for iOS and Android. And I hope this lecture was helpful. I would really appreciate any feedback you have about the content or things related to DDX of, and my email address is there if you'd like to reach out. So thank you all very much, and have a great day.